Today we want to study about the NAPLEX and USMLE exam review. It is a second lecture in the pharmacology subject. Review of the therapeutics in the pharmacology for the NAPLEX and USMLE exam. In this lecture I will speak about cardiovascular disorder, and the first part is about hypertension. In this part, we will study about the hypertension and the relation of the cardiovascular disorder and hypertension, and pathophysiological background of these diseases and how we can treat it. Cardiovascular disease or cardiovascular disorder is the first morbidity and mortality reason in the world. And there is several types of the cardiovascular disorder. The first one is hypertension. It can be because of the dyslipidemia, heart failure, and ischemic heart disease. In this lecture, we study about hypertension and the definition of the hypertension and which classification of the medicine we can use for hypertension. The hypertension, normal blood pressure, we can measure blood pressure in two forms: systolic blood pressure and diastolic blood pressure. Systolic blood pressure in the normal is the less than 120 millimeter mercury, and diastolic blood pressure is less than 80 millimeter mercury. But over these numbers, over 120 till 139 millimeter mercury for the systolic blood pressure is pre-hypertension. And for the diastolic blood pressure, more than 80 till 89 millimeter mercury is the diastolic blood pressure is pre-hypertension. But if the patient has no disease like diabetes mellitus or kidney failure, in this situation, with the lifestyle change, we can management of the blood pressure for the pre-hypertension. But if the patient has the illness, disorder, like diabetic mellitus or kidney failure or heart failure, we have to care about pre-hypertension also. In the hypertension, the systolic blood pressure is the more than 140 millimeter mercury and diastolic blood pressure more than 90 millimeter mercury. But there is several stages in the hypertension. The first stage, systolic blood pressure, is between 140 and 159, and the diastolic blood pressure usually between 90 and 99. It is the first stage of the blood pressure in the hypertension. But in the second stage, the blood pressure is more than 160 millimeter mercury and the systolic blood pressure is more than 100. After the second stage is emergency, or stage 3 or emergency stage, which the blood pressure is higher, maybe around 200 for systolic blood pressure, and diastolic also will be higher than 100. We study now about types. We have two types of the hypertension. We have primary essential hypertension or primary hypertension. The reason is unknown or genetic. It can be because of the vessel type and the histological background of the vessel, or it can be because of the cardiac muscles, and also can be because of the artery, or can be because of the sympathetic and parasympathetic nervous system in the CNS. But in the secondary hypertension, cause is because of the chronic kidney disease, can be or pheochromocytoma because of the tumor in the adrenal gland, or Cushing syndrome because of the high production of the cortisol or some medication. Usually increased body weight or BMI, body mass index, can cause also hypertension. Okay, in this situation, for example, if the patient hasn't high blood pressure in his life but start hypertension after, for example, unhealthy diet, or for example in the increase the body weight, in this situation it cannot include primary hypertension, because in the primary hypertension, the system of the hypertension is not because of the environmental effect or the diet or other things. Sign and symptom. Usually the blood pressure hypertension hasn't any sign or symptom, and in some person, because of the high blood pressure or hypertension, he or she cannot feel anything. But because of this, we can sometimes say for the hypertension is silent killer. And but after, for example, if we couldn't control the blood pressure and we have hypertension for a long time, in this situation, develop the target organ damage and uncontrolled chronic hypertension happen. And in this situation, then chronic disease can be developed. As you know, the blood pressure mainly controlled by the heart and the vessel. And for the control of the volume of the blood, kidney has an important effect. And in this situation, if a person has a hypertension, chronic hypertension, maybe after long time or after some time, it can have a cardiac disease. For example, angina, and the myocardial infarction, as you know, because of maybe the coronary vessel damage because of the hypertension, and it can cause inflammation of the coronary vessel, and in this situation maybe myocardial infarction happen. But when the blood pressure is high, and we know the left ventricle is responsible for the systematic support of the blood, in this situation left ventricular hypertrophy can be happen. Or cerebrovascular disease, as you know, when the person has a hypertension, inside the vessel we have a high pressure, and in this small vessel like a brain and CNS, maybe this increasing the blood pressure can damage the vessel on the rupture of the vessel, and can be cerebrovascular disease such as a stroke. And the third disease, in the chronic hypertension we can see renal disease. As you know, renal is responsible for the volume of the blood, and it controls the volume of the blood. Okay. Also, renal can be producing some hormones like renin, responsible for hypertension. Okay. In this situation, also renal disease can be because of the tubular or nephron. Because of this, you need many vessels inside the nephrons, and in this situation, maybe it can be the cause of the damage of the vessel in the nephron. And in this situation, for example, chronic kidney disease, nephritis, inflammation of the nephron can be happening in the person, and after that, the person filtration has a problem, and in this situation, for example, in the laboratory exam we can see glucose or protein in the urinary system, and maybe it can cause hypoalbuminemia, and also infection in the urinary system because of the glucose. If you goes in the tubular, can cause a bacterial infection also. Ophthalmic disease, as you know, the vessel of the eyes is very, very sensitive to pressure, and also it is very narrow, and it's very important. In the ophthalmic disease, for example, retinopathy and the blindness because of the increased pressure in the vessel. Also, it can cause increased pressure inside the eyes, and it's important. It can affect for pressure inside the eye. If increase, can affect for the optic nerve, and maybe can cause a blindness also in the person. Vascular disease, because as I said, the vascular relation between the hypertension is very important. In the vascular system, we have a alpha 1 receptor, which is we can cause a vasoconstriction, and in the very high blood pressure or in the hypertension, if it's still constant in the chronic situation, in this situation the vessels, the valve will be changed, and the valve shapes can be changed. It can affect, for example, in the vessel and the vascular system be different. Also, it can be also damaged. For example, peripheral arterial disease can be one of the important signs of this vessel disease. Treatment of the hypertension. The first treatment is the lifestyle modification, decrease consumption of the sodium, okay, fiber diet, and the low consumption of the fat and carbohydrate. The main purpose is to decrease the BMI, body mass index. High fiber diet also control the diet, because if you see the BMI or body weight with the control of diet can be decreased, and the moderation of the alcohol use, because alcohol also increase the body weight, but the main important can affect for the kidney, liver, and vessel. Second treatment of the hypertension is pharmacologic treatment or therapy. For the heart failure, we usually use diuretics, ACE inhibitor, angiotensin converting enzyme inhibitor, aldosterone antagonists, beta blockers, and angiotensin 2 receptor blockers. These groups, also in the exam we have to mention, it can use for the heart failure. And in the list, this and the next lectures, we will study about the groups of this medicine, and what is the property, what is the mechanism of action, and the metabolism. But in the post-myocardial infarction, we use mainly beta blocker, ACE inhibitor, and aldosterone antagonist, and angiotensin 2 receptor blocker. Usually we don't use. And in the NAPLEX and USMLE exam books, exactly mentioned for this situation, which beta blocker and ACE inhibitor and aldosterone antagonist is one of the important therapeutical purpose of the post myocardial infarction, because after myocardial infection, the heart partly or some part of the heart is damaged, and mainly this damage can be in the left ventricle, and in this situation we have to control the pressure in the coronary arteries, and also we have to also control the blood pressure of the body. In the high coronary disease risk, for example, we use beta blocker, diuretics, because we want to decrease volume of the blood, and also we want to decrease the pressure in the vessel, and ACE inhibitor and calcium channel blocker. As you know, calcium channel blocker can cause vasodilation, and the beta blocker also affect in the heart to decrease the power of the pump, and also it affects for the pressure which can cause with the cardiac muscles. In the diabetic mellitus we have to care, because in the diabetic mellitus mainly vessels hasn't properly function, and beta blocker, ACE inhibitor, and angiotensin 2 receptor blocker can be used with the calcium channel blockers. And as I mentioned, pre-hypertension for the diabetic mellitus patient, it is also dangerous as a hypertension for the normal person. And for the chronic kidney disease. As you know, kidney is one of the important organ control for the volume, and the vessels in the kidney sensitive for the pressure, and in the hypertension, if we cannot control and the nephron, the vessel has a high blood pressure, and the filtration and excretion will be has a problem. Will have a problem, because as you know, the filtration, as with the formula we will see later, is directly related to blood pressure. And maybe we use ACE inhibitor, angiotensin 2 receptor blocker is mainly we use for this system. And for the recurrent stroke prevention, if the patient had a stroke and we want to prevent for the second or third stroke, we can use ACE inhibitor and diuretics. For the treatment of the pre-hypertension, we have two classification. The patient has a CKD, chronic kidney disease or diabetic mellitus, or patient without chronic kidney disease or diabetic mellitus. In the first group, if the patient has a chronic kidney disease or diabetic mellitus, we have to use a pharmacologic therapy, but without chronic kidney disease or diabetic mellitus, lifestyle modification can help for us. Treatment of the hypertension in different stages. As I mentioned before, in different stages we need a different therapy, and also we have to care about the disease of the patient, if it's a secondary or primary hypertension. In the stage hypertension, if the patient hasn't the kidney failure, or for example, if they hasn't diabetic mellitus, we usually more therapy like Thiazide Diuretics and lifestyle modification we can use. And if not effective, maybe we use a 2 antihypertensive therapy with a lower dose, okay, but not higher dose. And but in this stage 2, we normally use 2 or 3 antihypertensive therapy with moderate dose. And if not effective, we can increase the dose. The first group is the thiazide group, diuretic. As I mentioned before, thiazide is in the main cardiovascular disease can be used. As you see in the picture, thiazide in this dark convoluted tubule cell affect black sodium chloride co-transport channel. In this situation, sodium and the chloride cannot come inside the distal convoluted tubule cells. In this situation, sodium amount will be decreased, and because of this situation, calcium can come inside the distal convoluted tubule. Because of the TRPV5 channels, it can easily come inside. And if you see here, the calcium absorption is increased. In this situation, the patient lost sodium and chloride, and also lost potassium is very important, because enhanced sodium delivery result in the potassium loss in the collecting duct, because if the sodium goes in this direction onto the collecting duct, in this situation in the collecting duct it will be reabsorbed, and in this situation potassium will be excretion and goes out. Thiazide diuretic lowers of the sodium and water and later it can cause loss of the potassium, hypokalemia, metabolic alkalosis. Because of the hypokalemia, increased calcium reabsorption. In the thiazide diuretic, as I showed in the last picture, they inhibit sodium and chloride ion reabsorption in the kidney, in the distal convoluted tube. It is the first step. Okay? Then sodium in the collecting ducts increasing. In this situation, because of the high concentration of sodium, some of the sodium will be reabsorbed, and the potassium will be excretion happen. Okay? In this situation, mainly this absorption is not strong as to increase the sodium of the blood, but it can cause the decrease the potassium of the blood. We have 5 medicines very important. The first one is chlorothiazide, and the brand name is Diuril. Mainly doses between the 500 milligram per day till 2000 milligram per day we can use for the patient. Chlorothiazide, as you see, the dose is higher. If you see it in this picture, it is almost more than 20 times dose of the drugs in the per day is for the chlorothiazide is high. Chlorothiazide absorption is orally poor, and because of this we have to use higher dose. Okay? Metabolism, this drug cannot be metabolized. Okay, for example, if you use 500 milligram, maybe the small amount, 50 milligram per day, is absorbed, and the high amount of this drug can be in the feces. And also in the blood, it cannot be metabolized. Excretion, as you see here, 10 to 15% is orally, and 90-60% unchanged drug can be excreted with the urine. And oral action, as you see here, because of the orally poor absorption within 2 hours, okay, and in the IV 15 minutes it can reach the peak of, and the peak effect after in the oral will be 4 hours after using orally. After 4 hours can be peak effect in the peak, and in the IV 30 minutes. And duration after action in the orally between 6 to 12 hours, and in the IV close to 2 hours. And half-life elimination is 45 to 120 minutes. And as I mentioned here, chlorothiazide binding to the protein is a lower. And the second drug in this group is Chlorthalidone. Okay? Opposite the chlorothiazide, this drug can absorb very well in the orally. In this situation, in the excretion in the urinary system, we can see primary as unchanged drug. In this situation, we can mention here chlorothalidone is metabolized in the liver, and the metabolized compound can excrete by the kidney and bile duct, and the amount of the metabolized is very low. Onset of action is also same of the chlorothiazide, and the duration of the action can be in the longer in the single dose, and because it has a high absorption between 24 to 48 hours, and the person, if he has a long-term dosing, it can be, this amount will be decreased, because I say, as I mentioned, hepatic metabolism is very low, and the kidney elimination, half-life elimination also is low for the single to 40 hours, and for the long-term dosing is more than 45 to 60 hours. The third drug is hydrochlorothiazide. Hydrochlorothiazide is structurally closer to the chlorothiazide, but it is more polar, and it has the orally absorption is good. Onset of action is lower, around 2 hours, and the peak can be between 2 or 6 hours. But elimination is low, and single dose between 24 to 48 hours, and the long term is a little more. And the half-life elimination is between 6 to 15 hours. As you mentioned, it is just a bit closer to the structurally closer to the chlorothiazide, but absorption is so much better, and the protein binding is around 40 to 68% can be bind to protein. As I mentioned, this type of the blood, because of they can bind the protein, the elimination will be needs more time, and the half-life elimination will be higher. Indapamide, it's also we can say lozole. For these drugs, we need very low amount. I forgot to say these parts. For the Chlorothalidone, we use a Talitone medicine, and the dosage it is around 12.5 and 100 milligram per day maximum. And also for hydrochlorothiazide, we use this starting dose is the same, 12.5, but the maximum dose can be maximum 50 milligram per day. But Indapamide or lozole is we need a very low amount of dose for the starting. Mainly daily dose is 1.25 and maximum can be 5. Absorption is very good. Urinary excretion 70%, okay, can be in the 48 hours, and because it has some hepatic metabolite. I say that, as I mentioned, hepatic metabolite in this group is lower, and we have to mention about it. Protein binding is moderate. In this situation, elimination half-life is a little higher, and is extensively hepatic metabolized for indapamide. And the half-life elimination is for this drug it's between the 14 to 24 hours. And the lozole is one of the famous brands for this medicine. And protein binding plasma for this drug is around 71 to 79%. The last medicine in this group is the metolazone. Metolazone has a good absorption in the oral. In this situation, we can use for orally. Xaroxolin is the brands, and the dosage starts from the lower 2.5 till 5 milligram per day. No metabolism in the liver, okay, but elimination is a little faster, because in this situation usually carrier with the higher protein binding effect, because 95% of these drugs can carry with the proteins, but the excretion with the kidney is a little faster compared to the other groups of these drugs. Primary side effect of this drug is the sulfur allergy. As you in the medicinal chemistry or medicinal pharmaceutical, we know Thiazide Diuretica have a sulfur in their structure. It's very important. If the patient has sulfur allergy in this situation, the patient cannot use this group of the medicine. Contraindication we spoke before, and I mention it again: hypokalemia, hypomagnesemia, hyponatremia, hypercalcemia, hyperglycemia, and hyperuricemia. I will show again the picture which we study again. As you see, in the distal convoluted tubule cells, thiazide black sodium and chloride co-transports. Sodium goes to the collecting duct. The concentration of the sodium in the collecting duct is increasing. In this situation, sodium reabsorbed in the collecting duct and the potassium excretion, and the situations potassium will be lower. But amount of the absorption of the sodium is very lower than which in the distal convolutable blacking. And also because the concentration of the sodium in the tubule increasing, sodium proton exchange will be work, and proton will be excretion, and sodium will be reabsorption. And in this situation, alkalosis happen also because hypokalemia, metabolism, and also alkalosis because of the secretion of the more proton. Increased calcium reabsorption, because as you are in the distal convoluted tubule, because of the sodium absorption is blocked, and calcium will be reabsorbed. And in this situation, calcium more reabsorbed, and because calcium will exchange with the sodium, and in this situation sodium channel here will be activated, and more sodium calcium exchange will be happen. Lower sodium facilitated calcium reabsorption by sodium calcium exchange. And next step, and K monetizing, it is about the ratio is we have to care about blood pressure. Okay, when we use a thiazide diuretic, we have to monitorize blood pressure, and we care about BUN per SCR, blood urea nitrogen per serum creatinine, because the normal ratio is between 10 per 1 or 20 per 1, and if the ratio is increasing, the increased ratio may be due to because of the heart failure or kidney failure, and we have to care about, because maybe we have a kidney failure in this situation, in this treatment. And in the last step, what we drug interaction in the we know in the bipolar patient, the person uses lithium. If the patient has a bipolar problem and uses lithium, they can increase the risk of lithium toxicity. In this situation, we have to decrease the amount of the lithium. In diabetic patient, as I mentioned, they can decrease anti-diabetic drug effect. Also, it's one of the important reasons for these groups. And in the last step, non-steroidal anti-inflammatory drugs decrease anti-hypertensive effect of these drugs. It's very important because sometimes the person has also inflammation and use non-steroidal anti-inflammatory drugs. And the potassium sparing diuretic in this group, these drugs inhibit sodium ion reabsorption in the collecting duct. And this situation, potassium will be sparing. There's two type of drugs in this group: Amiloride and Triamterene. This drug is a weaker hypertensive effect, and we always use as a two with other or three hypertensive therapy, and often we cannot use monotherapy. And it is one of the very good drugs for the combination with the thiazide, because these drugs increase the potassium of the blood, and the thiazide group will be decrease the potassium of the drug. In this combination, they are very, very good. Amiloride, the brands is we can use a generic and dosage between 5 and 10 milligram per day. Triamterene, and we use Diuril, and dose is 10 times more, around 50 milligram per day, maximum 100 milligram per day. As you see in here, Amiloride absorption is around 30 to 90%. In this situation, we can use a low dose. No metabolize in the liver, and excretion usually unchanged. Okay, and because sometimes also absorption is moderate, we can find it in the feces, and the protein binding is very minimal. And in this situation, as you see, we use a low dose. Triamterene absorption is very rapid, and the metabolism is mainly primary by the liver, with the mechanism of sulfate conjugate of hydroxytriamterene, and excretion 21% to 50% can be primarily metabolized. It can also have a secondary metabolite, we will mention in the next lecture. As you see, the interaction between these two compounds, in the Triamterene, instead of chloride, we have a lipophilic group. Okay, in this situation, absorption will be more rapid. This chloride decrease absorption effect, and it's very important. And we have two nitrogen ring here, and Also, this nitrogen in the pharmaceutical chemistry background is very important, these groups. Primary side effect, as you know, it is a hyperkalemia. It increases the potassium in the blood. It is also chronic kidney disease is one of the important problems. And the contraindication hyperkalemia, because of this we can use with the thiazide group this drug. And we have to care about, or we have to monitoring potassium ion level, blood pressure, and also BUN per SCR ratio, blood, urine nitrogen, serum creatinine ratio, which must be between 10/1 and 20/1. And also drug interaction with the potassium supplementary, ACE inhibitors, and ARB and NSAID, non-steroidal anti-inflammatory, angiotensin receptor blocker. Thiazide and potassium sparing diuretic, as I mentioned, can be very nicely combination. Triamterene and hydrochlorothiazide we can use in the drug with the name of the Thiazide or Microzide. As you see, it is a Thiazide. The amount is the Triamterene 50 milligram and the hydrochlorothiazide 25 milligram. And for the Microzide we use 25 milligram, which 37.5 is a Triamterene, and 25 milligram for the hydrochlorothiazide. And Amiloride and hydrochlorothiazide combination will be Diuretic, which we use Amiloride 5 milligram with the hydrochlorothiazide 50 milligram. I hope this lecture will be nice, and have a good time, and see you in the next lecture.